So what I'm going to talk to you about today is some really game-changing technology. When I did my cardiology fellowship, if somebody had told me that you'll be able to replace a heart valve without opening a chest, I would have said, put down the crack pipe, right? So I'm dating myself a little bit, but I did my cardiology fellowship 89 through 92, and then did an interventional year of cardiology in 93, and I came here in 93, and I've been here ever since. So in 30 years, right, when I came here, what I had was a wire that I could put down a coronary, and I had a balloon to open a blockage. Stents had not hit the scene yet. Okay. Since then, we've brought more than 30 new technologies to our operating room. Okay. And this is probably one of the premier things that we've done that has been game changing for patients, and has been, I think, a real boon, right? So transcatheter aortic valve replacement, TAVR, is what we're going to talk about. See if I can get these slides right here. This is the team that does this procedure. We've got our valve clinic coordinators. Crystal Hastings, who's been with us now, I think, for almost 7 years. Julia Powell and Tara DeGrazia are the three nurses who run this program, and talk about women that are on it and efficient and great communicators. They keep everything oiled and running. So a shout out to them and a big thank you to them. On the cardiac surgery side, we've had Dr. Wilson, who helped us start this program when we got it going. And then a few years ago, Dr. Logsdon joined us, and he's just been a tremendous plus to the program as well. So we've got some really good, solid cardiac surgeons. And now, when we started this program, there was just two of us that were doing these valves. We've hired now, over the last 4 years, two more guys who do the valves. And so that the team is now 4 operators that actually do the TAVRs. I'm going to talk about our index patient. Our first patient that we did was a 92-year-old patient. Mind you, when this patient was done, the only patients that we could do, that the FDA had approved this procedure for, were patients that were turned down by surgery. Okay? They were what we called high-risk patients, meaning their chance of dying from the surgery on the table during their hospitalization was higher than 10%. Okay? 8 to 10% in that range. So this was one of those patients. Now, he was a relatively healthy 92-year-old, but he was 92 years old anyway. He was pretty active. He had had progressive arthritis in his knees. He had become less active, but he was having shortness of breath. He would get tired very easily. Went from playing 18 holes of golf regularly to maybe playing 3 or 4. And then he was at a point where he was getting short of breath, just hitting balls on the range. And he was like, I don't want to go on like this. And he was losing his strength because he was doing less and less and less over a period of about a year or two. So he was the first patient that we did. This was in April of 2015. If you can believe it, this is 9 years now that we've been doing this procedure here. He went home after 2 days. Almost within a week, his symptoms had resolved, right? He was breathing normally. He was more energetic. He was not as tired. He went through the cardiac rehab program, which does so much for our patients. And after that, 3 months later, he had a knee replacement. Went back to playing 18 holes of golf after his cardiac rehab, right? And he continued to live independently for many years after. Actually passed away at 99 years of age, right? So he got 7 years out of that valve. We'll talk briefly about what is aortic stenosis. We'll talk about how we diagnose it and what the treatment options are and what we have here at Eisenhower. This is a little diagram. This is where your aortic valve lives, right? So this is the left-sided chamber of the heart, the left ventricle. This chamber pumps blood out of the aortic valve. This is the aortic valve here. And this is what a healthy aortic valve looks like. So if you're looking at it from above, it looks like a Mercedes sign. It's got 3 flappers in it. When it's closed, it looks like this. When it's open, it looks like this, right? And in patients who have aortic stenosis, what happens is they begin to develop calcium deposition on the valves. So this is an actual valve out of a patient, surgically exposed, and this is what the valve looks like. So you can see these big chunks of calcium that shouldn't even be there, right? So when this restriction is mild, the leaflets still open, although they don't open as well. But over a period of time, what happens is the scarring and this calcium becomes progressively worse, and it progresses to moderate and then to severe. And by the time you get to this moderate to severe range, most patients are starting to have symptoms. And the symptoms are those of chest pain with exertion, shortness of breath. Some people pass out or feel like they're going to pass out frequently. And some people actually develop abnormal heart rhythms as well. And this is all a function of progressively decreasing blood flow coming out of the heart. So there's less flow going to the head, which is why people start getting lightheaded and dizzy. Because there's this tight blockage that doesn't allow blood to come out of the heart properly, the blood begins to back up in the lungs become boggy with fluid, and you cannot exchange oxygen adequately. So that causes the shortness of breath. And then the arteries that supply blood to the heart itself come out just above where this valve is. So there's less blood coming out of the heart, there's less blood going to the heart. When people exert, they don't get enough blood to the heart muscle, and that's what gives them the chest pain. So those are the 3 cardinal signs of aortic stenosis, the symptoms. When we listen to these patients, you hear a murmur. Well, what's a murmur? The simplest way I can explain a murmur to you is if you take a garden hose that has water coming out of it and you stick your thumb on it, that water is going to come out faster, right? So as that valve narrows, the flow of blood coming through that valve increases, and it creates a whooshing sound. And that's what we hear with our stethoscopes. That's what a heart murmur is, okay? It also affects the sounds of the valves closing because these valves are rigid. They don't flap back together, so they don't make a nice crisp heart sound. And that's what we hear when we listen. That heart sound is attenuated, it is soft or it's absent. And then there's a decrease in the volume of pulse. So when I feel a patient's carotid artery or their radial pulse, it doesn't feel as strong. And that, again, is because of the narrowing in the outflow of the heart muscle. So here's what an echocardiogram looks like. This is an ultrasound of a normal looking heart, right? And you can see this little opening and closing line over here. That's your normal aortic valve. This is what a severely stenosed aortic valve looks like. And you can see how hardened it is and how the movement is significantly restricted. So this is in different views. Here we're looking at that valve end on, like the diagram I showed you earlier, right? It is, look, you can see this Mercedes sign opening and closing over here, right here. And then when it becomes hardened, it doesn't open and close like it should. So the leaflets are restricted. Yeah, sure. No, so look at this, just look at, sure, the question was, is there swelling in the bad? It's not swelling, it's the buildup of calcium. That's why it looks thickened. And there's scar tissue and there's calcium that's built up on this valve, right? That's why it's looking thickened right there. So these are the things that we measure. We actually measure the velocity of blood flow coming out through this valve. And in patients who have severe aortic stenosis, their velocity of blood flow is over 4 meters per second. Normal is less than 2, right? So when we can actually measure this with a Doppler. We put an ultrasound on the patient's chest, put a little gel on there, and we can actually measure the blood flow coming out of the heart. Using that, we can actually measure what the pressure drop across a valve is as well. And if that pressure drop is greater than 60, or greater than an average or a mean of 40, or if we calculate the valve area to be less than 1, we know that this patient is now in the severe aortic stenosis category. Well, what does that mean to the patient? If you're told you have severe aortic stenosis, what does that mean from a standpoint of prognosis? Your prognosis, if you have developed symptoms and you have severe aortic stenosis, is not good. 50% of these people will not be alive after 2 years. Okay? 20% of them are alive at 5 years, which means 80% of these people have died. So this prognosis is actually much worse than a lot of cancers, right? And what is it that we used to do for the valves? And well, we're still doing. This was what we called a SAVR, or surgical aortic valve replacement. And there were 3 ways to open the chest and replace the valve, right? This is the open chest or sternotomy procedure, where we actually cut right through the sternum. We spread the chest open. We put the patient on a heart-lung bypass machine. We pack the heart with ice. We actually stop the heart, cut the heart open, cut the valve out, size the valve by taking different cylinders and going, oh, it's a 25, it's a 26. Okay, give me a 26 valve. Put the valve in, sew it in, close the heart, suture the heart back together, the aorta back together, jump start it with paddles, and then wean the patient off the heart-lung bypass machine, okay? And our surgeons are really good. They do a spectacular job with this procedure, right? We've got 2 outstanding guys. It's also possible to do this surgery with a smaller incision, what's called an anterior thoracotomy, or a midline mini sternotomy, right? So the incision is smaller, depending upon the patient size and the valve size and what else you have to work around. But at the end of the day, it's an open surgical procedure. And this is all we had up until the time that we actually got TAVR technology available to us. Now, as you can well imagine, that is not necessarily the best kind of surgery for a patient who is elderly or frail. And we'll sort of go through that. Here's your survival for symptomatic patients with surgical aortic valve replacement, right? If you decided you were not going to operate on these patients, within 2 years, you can see this red line. You've lost about more than half these patients. Whereas the surgical aortic valve patients actually had sort of a normal longevity. So we knew that we were impacting mortality in patients by doing surgery and replacing their valves, right? But if you look at the actual numbers, every year about 250,000 patients meet an indication for a surgical aortic valve replacement. Historically, only about 80 to 85,000 patients have had open heart surgery, which means 2/3 of patients who could benefit from an aortic valve replacement are not getting it. Why are they not getting it? Because of these reasons. If you have a patient who's 85 or 90 years old, or if he's like our index patient that's 92, they might do fine during the surgery, but their recuperation, their recovery is just going to be a big struggle, right? So you would bring them through the surgery okay, but they never got their strength back because the recovery process was 4 weeks or 6 weeks, and they just didn't have the strength to work through that. So they became more frail, more weak, more limited in their ability to do anything. So you had patients who were frail, they were elderly, patients who'd had prior open heart surgery. Well, doing a second open heart is a little bit more challenging because now you're having to open the chest again, you're working through scar tissue, and now your patient is usually 10 or 12 or 15 years older than they were during their first surgery. So it's not a great option, right? Patients who've had a prior stroke, patients who've had kidney problems, lung disease, all of these things impact our ability to operate on these patients. So giving them an open surgical procedure was not necessarily a great choice. And what happened very quickly with our TAVR technology is that initially it was approved really for patients who were at prohibitive risk for surgery. So the sickest patients that the surgeons didn't want to operate on or were not great candidates for open surgery were the ones that we started with. Okay. That approval was in 2011, end of 2011. The high risk group got approved a year later. And this is all based on clinical trial information. So these trials were done where these patients who were prohibitive risk or high risk were randomized. So they had to put their hand in a hat and pull out a slip that said, well, you're getting an open procedure or you're getting a TAVR, right? Because this was still investigational at this point. And then these patients were followed for a year, 2 years, and 3 years. And what the data showed was that these patients were doing better with TAVR than they were with surgical valve replacement. That data was looked at for high-risk patients in 2012. It was looked at for intermediate risk patients in 2016. And in 2019, we actually got approval for patients who are low risk, right? So across the board for aortic stenosis, this treatment is now approved for all patients, right? It is less invasive, and you are actually able to deliver a valve to a beating heart. And that's the amazing part about this technology. How do we deliver this valve? The vast majority of the time we are delivering this valve from the transfemoral approach, meaning that we go through the artery in the leg, we thread this valve all the way up to the heart, and this is where the normal aortic valve sits, and that's where we deploy it. There are patients in whom these arteries in the legs are too small, or they're severely blocked with plaque, and we cannot get our equipment up in these patients. So to accommodate those patients, we have done this procedure in other ways. Our default procedure now, when we cannot go through the leg, is to come through the carotid artery. That artery is in your neck. It sits about ½ an inch below the surface of the skin. We can make a small incision here, expose the artery, actually put our catheters in from here, deliver the valve, get out with a couple of stitches, close this area, and we're done. Okay. It's done under general anesthesia, but it is much less invasive than doing an open sternotomy procedure. We've done subclavian here. We have done transapical. A transapical is where you actually make an incision in between the ribs. You take a small needle and you puncture the tip of the heart with it. You thread a wire in, and then over that wire, you put your catheters and deliver the valve into the heart. And on your way out, you stitch the heart closed, right? We did a few of those, and we decided pretty quickly that the carotid approach was a better approach. It was definitely easier. And then there's a direct aortic approach where you can make a small incision here and go directly into the aorta to deliver the valve. All of these surgical procedures in the chest carry their own risk and morbidity with them. So we've figured out that the less we do in that aspect, the better off the patient does. So we've taken a minimally invasive approach as much as we can. The technology is evolving. There are now 8 different valves that are available in various stages of approval and investigation. The 2 that are available in the United States are the Edwards valve, which is what our program has been built on from day one, and the Medtronic valve, which is the core valve. I won't speak to the other valves yet because most of them are not available here. One just came out and is probably still not quite as good as the platform that we are using. This is what the valve looks like. The frame of the valve is made out of cobalt chromium, so it's actually metallic, right? On the inside, this white part here, off-white part, these are 3 flappers made from the lining of a cow's heart. And these are actually sewn into the metal frame. And then at the bottom, you have this fabric, this skirt that helps seal the valve when it's delivered. When the valve goes into the heart, this is what it looks like. So on a chest X-ray, this is what you will see in a patient when we put a valve in them. That's about the size of a valve. So if you were looking at it from above, the largest size valve we have is about the size of a quarter. Okay, if you're looking at it from above, the circle that it makes. This is our delivery system. What we do is we actually take this valve, we mount it on this balloon, and then we crimp it. When we crimp it, it becomes about that size. Okay. Although this looks small, it isn't. This is about the size of my index finger. And so this is going to go through the artery in the leg all the way up to the heart, right? So that's why when we do one of these procedures, patients require CAT scans of the chest, abdomen, and pelvis, because I have to lay out the entire route where this device is going to go. I've got to make sure the arteries are large enough that they can accommodate this equipment. The actual delivery of the valve takes about 30 seconds. It takes me about a half hour to get the equipment in and a half hour to get the equipment out. But all of these procedures are planned out. When we do the TAVR valves, we actually do about 20 to 40 different measurements on the heart because we have to pick the exact size of the valve that we're going to use. This valve comes in 4 different sizes. I have to land this valve about 1 millimeter to 1.5 millimeters is my margin of error, right? So we really build a 3D model of the heart and make these measurements before we do any of these procedures. And it's not just me that's doing it. After this is done, we sit together as a team, our surgeons, all the valve operators, our nurses, the representatives from the company that makes the valve are there. We have a Wednesday morning conference, and we look at each patient's data. We look at all their studies, we look at their echoes, their angiograms, the sizing of the valves, this conversation back and forth. Should we do it this way? Should we land this a little higher? Should we land this a little lower? So there's a lot of input. It's a lot of heads coming together to try and make sure we have a great outcome. This is an animation. So this is the valve coming up the aorta. And the balloon is actually ahead of the crimped valve when we insert it to decrease the size. And then what we do is we pull the balloon back inside the valve. So this is the valve here, this little tube that you see here with the white skirt on it. And this is now my catheter. Now this is on a beating heart. We're going to come all the way around, up the aorta, around the arch. Here's your bad valve, right? And now what we're going to do is we're going to rapid pace this patient. And I'll explain that to you in just a second. You'll see the heart starting to flutter. We bring this in, position it carefully, bring the valve into the bad valve. Center it, and there's a way to flex and extend that arm on the catheter for me to decide what angle I want to lay it in the heart itself. And right now you see the heart fluttering. And that's when we expand this. Okay, that's how we deliver the valve. Now, the heart fluttering, I'll explain to you in a little more detail. And then the equipment just comes out, right? So if you think about trying to deliver a valve and landing it within 1 millimeter or 2 of margin of error, and you think a heart's beating 60, 80 times a minute, there's no way I'm going to land the valve where it needs to go. So what we do is we actually put a temporary pacemaker in the heart, and we speed the heart rate up to 200 beats a minute. When we do that, the heart, instead of beating like this, is fluttering, right? It's quivering. And it does that, and I can do that for 30 to 60 seconds for a patient without anything bad happening. But in those 30 or 60 seconds, I've got to land my valve where it needs to go. So if you walked into our operating room, there's a certain cadence to our procedures, right? There's pin drop silence when you come to this point. Nobody's talking. And I go pacer on. Pacemaker goes on, the heart started to flutter. Said, give me an injection. They inject the dye. We look at exactly where the valve is. I adjust. I take about 5 or 10 seconds to adjust where I want the valve. And I go balloon up. Right? That's your roller coaster. Everybody's waiting to see where the valve lands. Fortunately, we've done really well with it. Right? We managed to do a really good job and get really nice results. But that's how it's done. So this is an actual patient. This is the valve here. And you see the valve expanding now. So that was the animation. This is actually, and this little wire over here is our pacemaker. And now I'm pulling my equipment back. And this is what the new valve looks like when we look at it with echo. You can see nice thin leaflets that are opening and closing. You can see the chunks of calcium that were in the old valve have gotten pushed into the wall of the heart and the aorta, and that basically just becomes scar tissue. This is what my incision looks like when I'm going in. We actually have a little device called a perclose, and what we're able to do with that is we're able to deliver sutures into the artery. So the suture goes into the artery and out of the artery. And we deliver 2 of those. And these sutures are coming out of the skin. This is my tube through which the valve is delivered. When this tube comes out, I cinch the sutures down, and we have a little pusher. I can push the knot down onto the top of the artery underneath the skin. And that stops the bleeding. Right. So that's what our incision looks like when we're done. It's about the size of my little fingernail. Now, if you look at some of the trial data, this shows the improved survival in patients. This was called the partner trial. And the blue curve is the patients who were given standard therapy, and the yellow curve is the patients who received the transcatheter aortic valve replacements. And you can see there's a 20% reduction at 12 months in mortality. And that curve continues to diverge as time goes by, right? And the same data you see in patients at 1 year and 2 years, when on an intention to treat. I'll go through these slides quickly. They're meaningful, but basically the initial TAVR partner trials showed that we could substantially reduce mortality. 4 out of 5 patients had minimal heart failure symptoms after their valves. And procedural complications from the valve, from the TAVR procedure itself, were really infrequent. Here's the intermediate risk group. And even in this group, we had better outcomes with TAVR than we did with surgery. 20% risk reduction in mortality and disabling stroke. Here's the low risk trial. Again, superiority for the TAVR procedure versus surgical procedure. And this is a follow-up to 12 months. There's data now for 3 years and 5 years, and the numbers hold up. Here's the low-risk trial. Again, death or disabling stroke, better data for the TAVR procedure. Again, for quality of life issues, New York Heart Association class 2, 3, or 4, which is a way we grade the severity of the patient's shortness of breath, their propensity to retain fluid, had significant improvement in these patients, TAVR and surgery compared. So here's the different generations of the TAVR valves. The initial valves that we had did not have skirts on them. They were larger. in the delivery systems, which made for more complications from a vascular standpoint. But at this point, basically on our SAPIEN 3 platform, our mortality for these patients is right around 1%, which is pretty amazing to think about replacing a patient's heart valve with that low of a risk. Here's the associated stroke risk, somewhere between 1.5 and 2.5%. Again, much lower than surgical valve replacement. And somewhere around 2015, which is when we started our program, these curves of surgical and transcatheter valves started to cross over, right? Because the TAVR valves just started to exponentially increase, where the surgical valves sort of stayed pretty plateaued or stationary or a little bit downtrending towards 2019 and 20. Again, same things, talking about surgical mortality. I'm going to skip through these graphs. These are more academic. So who are your TAVR patients? The low-risk patient is your patient that's, in their 70s. They don't have horrible heart failure. They've got symptoms of some fatigue, some shortness of breath. They're really not frail. They're in pretty good shape. These are patients who had a risk of surgery somewhere in the 2% range of not doing well. So these are patients that would still potentially do very, very well with a surgical procedure. And there are patients in whom we say a surgical procedure is a better procedure than a TAVR procedure. And that's what the team looks at. Oh, I'm sorry, what happened here? The intermediate risk patient is a little bit older. They've got frailty indicators. Their surgical risk score is about 6%. So their chance of morbidity or mortality is in the 6% range. They may have other health problems, high blood pressure, diabetes, prior angioplasty or stents, but they're still very functional and no reason why we can't give them another 10 years of good quality life, right? And then you have your patients who are high risk, right? These are patients who are getting close to their 9th decades now. They've got significant frailty, right? Their surgical risk scores are high, greater than a 10% chance of having a problem with open surgery. So these are the patients whom the surgeons are not at all excited about operating on, right? And they previously would not have a choice. They would have to have these discussions with the patients and say, look, this is a big surgery and you may do fine, but it's going to be a haul. This is not an easy recovery. And there's chance of things not going well, right? So these are actually the patients that we started our valve program with, because that was all it was approved for initially. So what we've done at the heart valve program is basically to identify, evaluate, and appropriately treat these patients. We've got a multidisciplinary team that looks at this, and we feel like we've brought the best heads together to give our patients a really good outcome. You have not just the operators themselves, but you have the referring cardiologists. A lot of cardiologists are general cardiologists. They don't do these procedures. It's the interventional guys that do these procedures. But that's where most patients start with, is their general cardiologist. They're the ones that do their echoes. They make their diagnosis by hearing the heart murmur. And once they've made that diagnosis, then they get referred to the heart team. When they're referred to the heart team, our nurses take over, our valve clinic coordinators take over, they organize the CAT scans. The interventional cardiologists take over and do their angiograms, bring them in, make sure they don't have any blocked arteries. If they have blocked arteries, those arteries have to be fixed before we do the valve. And the reason for that is when you think about the fact that you are going to speed someone's heart rate up to 200 beats a minute when you're delivering this valve. If there's an underlying artery in that heart that's blocked, what will happen is you'll precipitate a heart attack, right? So that lack of blood supply that comes from a blocked artery has to be corrected before we do the valve. That's why we do an angiogram first. The patient is seen by the cardiac surgeon. We discuss this in our meetings every Wednesday morning. We have an anesthesiologist team. We have like 4 anesthesiologists that are cardiac anesthesiologists that are the only ones that scrub our cases. We have radiologists that help us look at the CT scans and process the images and make our measurements for these valves. So it's a concerted multidisciplinary team that puts all of this together. So we confirm your diagnosis, we evaluate by echo, we do an angiogram, you get your CT scan, you see the cardiac surgeon, and we discuss this in our meetings together. And then we decide, are we moving forward with surgical or are we moving forward with a transcatheter valve replacement? And these are, we already talked about the different ways we can do this. We can go peripheral, we can go transaortic. There's the surgical options. Since we started this program in April of 2015, we've done over 1,000 patients. Last year, we treated 169 patients. We sort of had a drop off in the summer. This year, we are actually on track to do probably somewhere between 220 and 250 patients, right? So it's an exponential growth. We are now doing patients without anesthesia, all right? That doesn't mean they're awake, they're sleeping, but they're not on a ventilator, right? They're not on a ventilator. It's not like we've taken over their breathing capability. They're on a propofol drip and they're asleep, but I can actually wake a patient up and talk to them if I want to during the procedure, right? So 95% of our patients are being done that way now, right? Our average procedure time is 70 minutes. The first valve I did here took me 3 hours and 45 minutes. The fastest valve we've done here, skin to skin, is 17 minutes. 17 minutes, right? And that speaks to the proficiency of the operators, the team, the nurses, the scrub techs. It is a well-executed dance that happens in that operating room, right? And our program is being held up as an example to a lot of the programs in the country, and I'll come to that shortly. 90% of our patients are going home the next morning, so their average length of stay is under 24 hours. And our metrics are better or as good as the best centers in the country at this point. We're actually now the only center that the manufacturer of this valve has identified as a benchmark site that brings in teams from around the country, right? So we have now had had 3 teams. We've had a team come in from San Diego, from one of the hospitals there. We've had a team fly in from Houston. We've got a team that is set up and coming next month as well. And it's basically one team that comes in every month now is what we're going to be doing. The surgeon comes in, the interventional cardiologist, the scrub techs, the nurses, the anesthesiologists. So the team is somewhere between 6 and 8 people that fly in. And what we do is we divvy them up early in the morning. We put the scrub techs with the scrub techs. We put the nurses with the nurses. We put the x-ray techs with the x-ray techs. The cardiologists and surgeons hang out with us. And then we rotate them through the cases so that they see every aspect of our program. And what we've done is basically we've achieved efficiencies and outcomes that have allowed us now to be in the top 7% of valve programs in North America, right? So the alternative vascular access, which is the transcarotid access, we are now one of the largest centers on the West Coast that does this. We've done 85 cases here at Eisenhower through a carotid approach. Um, and these patients have done amazingly well, amazingly well. We are routinely doing probably 2 or 3 a month now of these cases. And that's another reason that the manufacturer of the valve wants to bring teams in from outside so that they can actually see this approach, right? We've used the other approaches, but this has now become our default approach. We've really sort of got this honed down, and we're doing really well with it. The other thing that has been a big boon for patients who've already had surgery, who've had previous valve replacements, is that they now don't have to have another valve replacement when that valve goes bad. Most of these valves that were put in surgically have a life somewhere between 10 and 16 years. So they were 70 and they had a valve. Now they're 85 and their valve has gone bad. It's very difficult to talk to an 85-year-old and talk to them about opening their chest again. So what we're actually able to do is put a TAVR valve inside the old valve, right? And we've done that. This is just we've done a aortic valve in valve in 51 cases. We've done a mitral valve in valve in 11 cases, right? And the mitral is also a valve that sits on the left side of the heart. But when we are doing a mitral valve in valve, what we do is instead of going into the femoral artery, we go into the femoral vein. We go up the right side of the heart and we actually puncture through the septum, which is what divides the upper two chambers of the heart. And we deliver the valve through that into the mitral valve, right? This is what the procedure would look like. You can see this sewing ring here is the old valve. And we basically are able to expand our valve inside of this valve. Now, what's interesting is sometimes you do this and you don't get full expansion because the old valve is rigid and hard. You know, it has a frame. We've actually been able to fracture that frame, right? There's a balloon that's made out of Kevlar. It's called a true balloon. You can take this balloon to 20 times the pressure inside your car tire, and it does not grow in size. So we will see what size we want this valve expanded to, and we will take this valve into the valve that we've already laid inside the old valve. And then we will actually fracture the frame of the old valve to get full expansion of the new valve that we've put in, right? Here's just some examples. You can see this is a old surgical valve, and all this blue that you're seeing flowing over here is the valve leaking severely now because the leaflets have degenerated. The patient has heart failure. He's having to take diuretics. You can see the old frame. See this sort of wire here, and this is our new valve going up inside the frame of the old valve. And so when you repeat the echo, there's no leak at all. All that blue flare that you were seeing is gone. Here's your mitral valve in valve. Similarly, we're coming across the septum here. Instead of coming from the arterial side, we're coming from the venous side. And so here what you do is you actually turn the valve the other way. So this valve is going in upside down because the direction of blood flow is this way. You have to pay special attention to make sure you're doing that correctly. It's actually part of our protocol. So when we're putting the valve in, part of what we call out loud, skirt is down. So the scrub tech loads the valve on the wire that's going in. He says, skirt is down. I look at it and I go, skirt is down. So there's a checkpoint, double checkpoint on everything, right? Because things are moving so quickly that there's no room for error. So we have to build things into our protocols and our systems that prevent anything happening that is unaccounted for. So here's the valve, a mitral valve, and you can see this mitral valve is leaking up here. It's that red flare going backwards. And this is us now coming across from the right side of the heart into the left side of the heart. This patient actually has 2 surgical valves already. Now we just put a TAVR valve inside the mitral valve. And so when you repeat the echo, all that leak that you were seeing is gone, and you can see the leaflets of the valve are nice and crisp and clean. That's our valve program. That's our people, and that's our phone number. So I'll take questions. Thank you. Yes.
Excuse me. It's going to be quick. I'm 95.
Yep.
Do I qualify?
Yes, you do.
I do qualify.
The oldest patient we've done is 99. Right? I
Okay.
talked to her about having a valve done when she was 98.
Mhm.
And she was like, I think I've lived a happy life. I'm not sure I want all this done. I said, that's fine. I said, we're not trying to keep you alive for another 20 years. This is about quality of life here. You're short of breath. You're getting tired easily.
Well, I work out 5 days a week,
Oh,
and I don't know if I qualify or not, but I think I'm in good to keep myself pretty healthy. I don't have shortness of breath, anything, but
well, then you
Just
probably don't
wondered.
need it.
Pardon?
That's great.
Thank you, doctor.
Sure.
What if you have a pacemaker that's inserted in your heart?
Already.
Yes, and what happens then with this device?
It's not a problem.
No problem?
No problem at all. Yeah, what we're actually able to do is the temporary pacemaker we put in overrides the permanent pacemaker that's already there. And because the temporary pacemaker is going at a rate of 200, the permanent pacemaker sees that electrical activity and it doesn't fire when we're working.
Okay, thank you.
Is there a question back here? Oh, there. Hi, I have a couple of questions actually. And
Sure.
my wife just had a TAVR 2 weeks ago, so by Dr. Khanna, and it's amazing. So I'm kind of glad I didn't know all this actually. But these are curiosity questions. You said the device that you stick the valve in is about the size of your pinky or something.
Yeah.
How big is the femoral artery?
So the femoral artery, depending on the size of the person, can vary from 4 millimeters up to 8 millimeters, sometimes 10 millimeters.
That's
So you're
bigger than
talking-
your pinky?
That's bigger than my pinky. Yeah. So 10 millimeters is about a half inch. 12 millimeters would be about a half an inch.
Okay.
And that's what we have to size. If the artery is too small, then we don't go there,
Mm.
right? Because then you run the risk of damaging that artery, and then you have to repair it on the way out.
That's what I was wondering.
Right.
And my second question was regarding the temporary pacemaker. You said there's a little wire in there.
Yep.
Where does that go in?
It goes in from the groin.
The same
Yep.
with all the other stuff?
Absolutely. Yep.
Thank
And it
you.
comes out after the procedure. We're done. Yeah.
And then you have to like place it somewhere or attach it to something?
It actually has to go, there are 2 types of pacemakers we use. One we use sits in the apex of the right ventricle, on the right side of the heart. The other that we have now started to use probably in the last 8 months is we attach a pacing cable to the wire that sits in the left ventricle, which is the wire that we deliver the valve on. So we've taken that pacemaker that used to go into the right side of the heart out of the equation. It's what I was talking to you about, where we're looking at a minimalist approach. And what we know is that the less we do, the less chance there is of having a problem, right? So you figure out how to do it efficiently and safely. Yes.
My question has to do with the patient who already has had a valve replacement.
Yep.
Is there any difference in who would qualify for this procedure if they have a mechanical valve versus an animal valve?
Yeah, great question. So
If you
we
could
cannot
repeat the
do-
question, doctor.
so the question was for patients who've already had valve surgery, is there a difference in whether a patient qualifies for this procedure if they have a mechanical valve or a tissue valve? That's your question, correct? Yes. So we cannot do a mechanical valve, right? The mechanical valve has metallic leaflets in it, and they're usually hinged in such a way that if you try and do anything with it, it entirely disrupts the valve. And if you were to put this valve inside that kind of a valve, you'd never be able to expand it properly. So metallic valves are really not an option, right, to do this procedure. Fortunately, fewer and fewer people are actually getting metallic valves anymore, right? And the reason for that is when we're doing these procedures, we talk about not what the patient needs today, but what they're going to need over their lifetime. So for instance, when I'm seeing a patient who is 70 and they need a valve replacement, an aortic valve replacement, I know that no matter what valve I give that patient, there's a significant possibility they're going to require a second valve during their lifetime. The advantage of the TAVR valve is that I can put another TAVR valve inside the TAVR valve, right? So if I get 10 or 15 years out of one, I can repeat that procedure 15 years later and get a second one. So at 70 years, I've given them another 20 to 30 years with two valves. So that's kind of what we think about and what we talk about when we're making these decisions. There are patients that are 60 years old in whom we think, depending on the kind of valve they have, if they have what we call a bicuspid valve and they have an aneurysm that goes along with a bicuspid valve, in those patients, surgery is a much better option than trying to do a TAVR, because there you repair the aneurysm and you replace the valve. But when we do that, we know that 15 years later, we're going to come back and put a TAVR inside the valve we gave them, right? So we have these discussions with patients about what are we going to do 10 years from now and 15 years from now, right? And that's important because you've got to plan for that.
Thank you. Thank you for the nice things you said about the volunteers. I
Sure.
appreciate that. Dr. Khanna, Dr. Beckerman is going to refer me to you someday very soon. I have the mitral valve issue. So of course you'll do all the testing and all of that. When do you decide whether to repair with a clip or
Yeah.
replace? And how long have you been replacing the mitral valve? It was my understanding has a slightly different shape than the aortic valve, which is
Yeah.
perfectly round. And that was the challenge of the replacement. And how many have you done at
Yeah.
the hospital?
So I'm actually, I helped start the mitral program, but I've actually stepped away from the mitral program. I'm not doing mitral valves. I do valve and valve mitrals, but I don't do mitral repairs. The clips I don't do, okay? Part of it was I just had too much on my plate. It was like, I needed to decompress what I was doing. But the mitral repair, the percutaneous mitral repair, what we call a TEER, T-E-E-R, a transcatheter edge-to-edge repair, is where we go in and we actually grab the leaflets of the mitral valve itself, and we clip them together, right? And what that does is it decreases the leak across the valve. Now, that's a way to repair a leaking valve. It doesn't completely eliminate the leak, but it decreases it more often than not from severe to mild to moderate, enough to where a patient has a significant improvement in their symptoms. There are transcatheter mitral valve replacements coming. They're investigational, and there are patients that we refer out because we don't have that available here yet, right? We probably will have that available within a few years. Is it a year, 2 years, 3 years? I'm not sure, but we are definitely on the radar of all the companies that manufacture these valves now. So we're getting involved with more and more clinical trials in the valve space as well. There's mitral valve replacements coming. There's a tricuspid valve replacement that just got approved. But the company that manufactures it is also Edwards, and they're doing a very limited release. There's about, I think, 3 or 4 centers on the entire West Coast where they've released it. And those were actually the centers that were the investigational sites for the valve, right? So there's a lot coming. And what's right for a patient, you can't make a general statement. You have to look at every little detail about the valve, about the patient, and then say, here's what I think we should do.
I have one more quick side question. I hear you are the king of the catheter, heart catheterization program, that you have all the complicated ones. They refer them all to you, that you can take care of those issues. Is that correct? Yes, you are. And my bypass is 22 years old, and Dr. Beckerman said, you know, we really need to take a close look, and I'm going to definitely send you to Dr. Khanna for that. So,
Yeah.
but I know that that is your specialty also.
Well, I've been doing it for 30 years, so there's a little bit of experience behind all of that. And the entire 30 years, the one thing that I've always tried to do is stay up to date and help innovate and invent. So I've actually been involved in one way or another with the development of 14 new devices. I have some of my own patents. We've taken 12 companies from small startups to in the cath lab, ideas that started on a napkin and are now being used in 1,500 hospitals across the country. You have to be able to think out of the box to look after patients. It's important. I encourage all the junior guys that join our groups, our group, to do that as well. Your patients help you find better ways to look after them, but you have to be committed to doing that. About 7 years ago, it's more than that, maybe it's 10 years ago now, had somebody come to me that had a very rare problem. And because I do not just heart work, I work in the arteries in the legs, I work on valve issues, I work with a bunch of innovations and companies that develop new products. This was an 84-year-old that would have required another open heart surgery. He had bad lungs, he had bad kidneys. His mortality on the table, surgical table, was 30%. Right? And he said, well, what if I don't do anything? And what he had was he had an aneurysm of a vein graft. So it was found just by chance because he had a chest x-ray and they thought he had lung cancer because this thing was about the size of an orange. Right? And it's not very common, but it happens. And people never know they have it. It blows and they die. It's instantaneous. You don't survive it, right? And so he came to me and I said to him, I knew he was coming and I'd looked at all his pictures and his CAT scans. And I'm a little bit of an insomniac. 4.5 hours of sleep is about what I need. And at 3 o'clock in the morning, I'm sitting there stretching out ideas on how to fix this guy's problem. For about a week, I kept doing that because I was convinced I could help this guy. And I did literature searches and I couldn't find anywhere that it was described what I was planning to do with him. I told him, I said, when you come in, please bring your family with you because we're going to have a conversation about how to address this. And he came in with his son and his daughter. And what we ended up doing, I said, look, this is off label. Okay? I'm going to fix your problem, but I'm going to use something that's normally a stent that's normally used in the bile duct. I'm going to use a product that's normally used to protect people from strokes when a carotid stent is being put in. I'm going to use a product that there were about 6 different fields in which products had to be pulled from to make this happen. And he said, have you ever done this before? I said, no, I haven't. He said, who's done this before? I said, nobody has. So, well, what makes you think you can do it? I said, because I think I can do it. And he said, what do you think my chances are of dying on the table or having a complication from this? I think it's less than 2%. He said, let's go, let's do it. And so we did this procedure for him, right? He went on to live for another 9 years. I presented that case, I sent that case, and we have a conference called the Transcatheter Therapeutics Conference, a PCT conference. It's the biggest conference of interventional cardiologists in the country. There are 40,000 people there. And people from all over the world send their cases in for best case of the year, right? There's usually about 1,500 cases that get turned in. I got best case of the year that year. I got to stand up there and present it. Right? But that's what keeps you going, right? And yes, you're right. I do tackle a lot of difficult cases. But you have to be, if you do that, you never stop growing. You never stop learning. And if you're staying committed to trying to help a patient, you just continue to improve at what you do. There's just so much happiness and satisfaction in that. You can't replace it. So it's very fulfilling. All right. Great. Thank you.